Okay, I'm just testing first off that this microphone is on.
I gotcha.
Can you hear me, Claire?
Yep, loud and clear.
Dr. Tessman?
I'm here.
Are
you
Hi,
hearing me?
everybody. I am Sarah Shea, and I'm a WSS parent. I'm here with my daughter, Ivy, who is 6 years old, and my parents, Lynn and Bob Shea. We drove up from Asheville, North Carolina, and I'm here to introduce a very dear friend who's been a tremendous resource in our life, because my child did not come with an instruction manual. It would have been helpful, but no. I have been really blessed to have a friend and resource, Dr. Claire Tessman. We go back a bit. We're actually have a personal connection. Claire and I were college roommates at Kenyon College, and have been dear friends for years. I was an English major at Kenyon, so I really did not have much experience in the field of medicine. Claire was interested in neuropsych. So when I had a child with a genetic difference and I began looking and thinking about different medications and the pros and cons of those, I just felt really lucky to have a resource in Claire, and we have brainstormed. Claire has done tremendous research on my behalf on Wiedemann-Steiner syndrome, and we've learned a lot together, and she has helped me think through a lot of resources for Ivy. Dr. Tessman has been working in youth health and wellness for over 20 years, most recently with nearly a decade working as a psychiatric nurse practitioner focused on improving mental health care for people of all ages, especially those affected by developmental and related disabilities. Training at Cincinnati Children's Hospital, University of Chicago, and the Neuropsychiatric Institute of UIC, University of Illinois at Chicago, convinced Dr. Tessman that a clinic offering lifelong practical care was the optimal method for avoiding yet another transition over adolescence. The medical home model and the social model of disability have been essential to her career. Dr. Tessman is now completing a doctorate in nursing practice while also parenting. Actually, our children, our little girls are only a year apart in age, and continuing to provide outpatient psychiatric care, being a connection for youth who, like her, don't get all their needs met from typical social settings, essential to her goals. I am delighted to introduce Dr. Claire Tessman.
Thank you so much. Thank you, Sarah, and thank all of you for making it there. I'm just thrilled to be able to speak to you today, and really just watching the room there, I'm able to feel the love, just feel the affection and genuine openness you all have to providing the best care you can as family and caregivers. My goal today, and we could go to the slide that says, oh yeah, so enough is enough, right? I think very often there's this sense that there can never be enough, or that you have to demonstrate or prove that there's enough. You saying that there's enough going on to warrant searching for new solutions, that's enough. So that was the point of that one. Next slide, I don't have any relevant disclosures. And the next slide, talking about goals and objectives for today, I want to improve your confidence in discussing treatment options surrounding mental health, to build skills for ongoing communicating about accessing evidence-based care for WSS and for all your loved ones and for yourselves, for all of you personally affected, and equip you with language and some ideas of how to get resources and access and ongoing treatment of mood, anxiety, attention, concentration, and really finding ways to be healing from fears and from distress. And just to know that you have enough skills, right, to trust yourself. You can go to the next one, which is really about like that whole self experience. We all have been children and teens, and now sort of the process of sort of understanding a really diverse population of folks that we have so much love for, means that we're exploring a new way of what support means. And I know that interpersonal support, the network of friendships, families, is really part of medicine. It's part of what can heal us and create safety nets for being safe with one another, and for expanding the care networks for our loved ones. Making access easier is key for me, and spreading the truth that joy and struggle are not always separate, right? And sometimes it may be really hard to say, like, what is it that I really need help with? Because you have moments of greatness and then moments of really intense struggle. Throughout all of that, progress can be right around the corner and sometimes comes out of nowhere. So while working on treating mental health, we really have to acknowledge that we can never know what is happening in another person's mind, right? So you as the people closest to this, when you're seeking help, trust your intuition. That's one of the biggest messages I want to give you, is to trust yourself, and really insist that providers do too. One of the things I want to highlight is that I know there are providers out there, for one reason or another, burnout, ignorance, are going to be educated by you. And as you're doing that, trusting that you have enough knowledge to do that educating just because of your close connections, that's important. Next slide. Discusses the concept of social model of disability. I hope at least some of you have heard of this, in somewhat of opposition to the medical model of disability, which is sort of focused on what's different, and even uses the word wrong, and creates deficit-based definitions, right? Attention deficit, oh dear. Really, I mean, a lot of those folks with attention deficit actually can have intense amounts of attention to particular things. So we know that a lot of that language is not accurate and doesn't really help us understand the neurodiverse strengths that people have. The social model recognizes it that, in a physical model, it's the stairs that are the problem, not the person who can't do stairs. So, so broadly, the structure of a learning environment or a care space, a care environment, the expectations that are placed on people, which are often unrealistic, those are the things we need to study and find out how to change, right? How to make accommodations, and to realize that those are necessary and they improve society for everyone. So some examples that I'm sure some of you have dealt with is like this requirement that you lose your appointment if you're not early or right on time. When you have, you're dealing with obstacles and barriers to access, being on time can be a major battle. Another thing we encounter is stigma, in the sense that people are not as welcome if their differences are highlighted or obvious. And that can be even surrounding just a simple thing as like missing school for appointments. Like that just needs to be accepted and just fine. And of course, the whole system matters, right? So family and work systems that don't support primary caregivers and honor the extreme and sometimes impossible seeming effort that goes along with all the love that you have. So the next slide, I want to talk a little bit about mood states and the fact that characteristics of any one person's mood state and their capacity to cope with stress plays a huge role in how it needs to be treated and discussed, right? It's not as simple as, oh, you fall under this diagnostic category and therefore this is the answer. It's never that simple. It needs to be individualized for everyone, especially in the case where we know that there are genetic differences that kind of can bring up extra layers of risk. I do want to highlight the reality that play therapy and family systems, not just the primary caregiver, but the whole family system really, really works and is a great resource to tap into. I know you all are great resources for each other and probably have ideas about how to connect with that. But then I also want to say that sometimes lab abnormalities, nutritional deficits really play a role in mental health and wellness, right? So activation of the stress hormone systems in the body sometimes can be triggered by deficiencies in nutrients. And with WSS appetite and nutritional struggles and all the different ways that your loved ones and you need to get nutrition, this is something to really be on your providers about, making sure that it's being studied and sort of checked, especially surrounding, I would say for mental health purposes, folate, B12, and vitamin D, right? Okay, so this is a little bit of a tricky thing, but I do want to say that if we're looking at mood treatment, we're going to want to look at least having daily medication of an SSRI, if that's what we're trying, for a month, right? And sometimes that can be a battle if you're trying to figure out how to even administer this. And that you can tell your providers that one of the biggest things is to start with low doses and see if low doses really work, and only increase the dose if it's really obvious that there's no concerning or intolerable side effects. I'm going to go through a couple of the medicines that are most often used for coping with anxiety systems in the body. And that in people who are speaking and highly verbal all the way to non-speaking folks, these systems of anxiety and mood are similarly manifesting, right? It's people are people. And so there are some providers who will sort of say, oh, I don't have any expertise in this. You can tell them they don't need expertise. My loved one is a person and you can treat them like a person. And yes, starting with low doses is a great thing, but still you can sort of trust that there is knowledge, even if somebody has not treated someone's WSS previously. So a couple of medications on this list for mood and coping with anxiety include sertraline, which is really more activating. Usually it should be given in the morning if the morning is the time that you want to start activation. And it's useful for melancholy, which I think manifests in all kinds of different ways, but often sort of more withdrawal, right? And just sort of receding, and a change in one's level of melancholy can be a result of lifestyle changes, can be a result of a change in hormone levels, can become less engaged in their surroundings. And, I think that this type of medicine, sertraline in particular, is more activating for working on that level of dysthymia, which is sort of a chronic low level lasting for, more than 2 months. And I wouldn't suggest sertraline if there are sort of more of these impulsive and histories of sort of more manic type of experiences or insomnia. Sertraline is not so great. For insomnia, along with mood struggles and anxiety, Lexapro is a really good bet. It is faster acting. You don't always have to wait that whole month or even longer to see the benefit of it. It's a little bit more sedating, so it's a nighttime SSRI. And young kids can start with even half the 5 milligram. And I would recommend for WSS folks to see if half the milligram for 2 or 3 weeks starts to improve things, and see if you can keep the dose really low, right? The side effects come with higher doses, right? Almost all these medications, it's really a dose-related side effect curve. So, there can be an increase up to 5 milligrams if you're feeling confident about that and had experience with this, and your provider wants to push it. But I would say 20 milligrams is the best result, is more for adults, more for people who have done growing. Ruminating, turning things over and over again. This is something I see a lot for WSS, like this sort of getting stuck in a certain state. That anxious, sort of depressed might not be the right word, right? It's this turning it over and over and over again, getting stuck. Urinary retention, if you've seen that in your loved one, if you've got that, it's not as good of an option because of the potential that Lexapro can contribute to more urinary retention. Go to the next slide. A little bit more about fluoxetine, which I think is an excellent option, partly because super low doses can still have big effects once you get to steady state. That means that the medicine is in the system at a regular level over the course of weeks. The harder thing with fluoxetine, which is brand name Prozac, is that it's more of like a 4 to 6 week window that you have to be taking it in order to see the benefit, right? So it's not as good if you're suspecting that some of your family members might not get, or it is better. Sorry, it's better if you think like, oh, they may not take it a day or 2 a week because they might be out doing something else or busy, or with a parent who's maybe going to forget it, right? Fluoxetine is safer if you're going to miss doses of something. And it can be given any time of day, so there's a little more flexibility. One of the things that sometimes occurs with onset of these kinds of medicines is a little bit of tummy newness, like a difference in how the gut is working, right? So that can be anything from looser bowels, which I think many of you will say, oh, I could welcome that, but it could also mean a little bit of constipation. So making sure that hydration levels are good. I don't know how relevant the menarche and menopause, menstruation and dysphoria associated with that is, but fluoxetine is often really helpful for that too, even with a little increase in dose during that part of the cycle that can really reduce irritability and frustration that sometimes gets worse there. Celexa is not something I would recommend with WSS just because of the organ systems that have a harder time with it. Lexapro is a safer version of this similar medicine, and it ends up being useful at a lower dose. Luvox is something that I have not found evidence of being used in WSS, but I'm sure somebody's doing it. Luvox has this dangerously close to fluoxetine name. That's why I capitalized that Vox part. It's more for that OCD kind of getting stuck, repetitive stuff, repetitive movements. It can be sometimes helpful for the distress associated with movements like tics. People, I don't know how much this happens with anyone you love, but there's a way that escalating frustration can coincide with movements that feel out of control. And Luvox is something that helps quite a bit with that. It is quite sedating and generally given at night, and is one of these things that needs like a month to 6 weeks to get to the right dose and to really see if it's working. I do not recommend Paxil. The metabolic features in WSS make me think that this is just not a good option. We can move on to the next and talk a little bit about attention and concentration and what I prefer to call variable attention stimuli trait, right? That the attention can be very focused, but it's maybe not always on the thing that you're hoping to focus on. And it goes along with intellectual disability. And I use that term with so much respect for the reality that everyone's intellectual capacity is different and everyone's is valid. Therapy is such a crucial step towards coping with this. We as parents can learn new language for building habits, make it playful to make new habits, and habits can make things so much easier when a 10 is not naturally coming to the things that we aren't having as much fun with, right? So less desirable tasks and chores and struggles when you have the routines around them. I'm sure many of you have discovered the routine makes it so much easier. If transitions are very difficult, learning to share attention with your loved one, child, adolescent, adult, all the way through, right? Sharing attention on whatever it is that it's time to transition from. It's like building a bridge, right? You sort of share the attention on what they're doing, try to really get on their level, and then, build that bridge to what's next with gentleness and what I would call warm clarity, right? Sort of, we need to do this. I can't let you keep doing this other thing. It's great. I know it's hard. We're going to do it together. Connected parenting is a set of tools that I have seen help many folks with genetic variants of all kinds, and it's a set of really principles and theories that derive from the reality that a human experience is meant to be shared. And even when folks are withdrawing and needing extra supports, there's still a benefit to sharing. Dr. Ross Green has done a lot on how folks who are feeling powerless may end up with sort of extreme behaviors sometimes that we're not sure how to cope with. And this hour-long YouTube video of moving from power and control to collaboration and problem solving has tidbits that I think will help all families. So that's the therapy piece, because I think it's really understandable that folks are reluctant to use any medication for WSS folks with that is going to reduce appetite, right? We don't want to reduce appetite, and ADHD symptoms often coincide a lot with anxiety, right? So anxiety may be the thing that we need to treat first and see how we can get through and improve coping with that. There's a medication called guanfacine extended release. If the 24-hour version seems out of reach at first, there's also an immediate release version that can be started as little as 0.5 milligram to sort of help the systems of the body that regulate blood pressure and blood flow to certain parts of the brain be more consistent. One of the things that fires off anxiety and then pulling the brain towards only the familiar and only the things we want to stay the same, that part of the brain can get fired up when it's not getting the same regulated amount of blood pressure. So guanfacine is a blood pressure medicine that actually helps the brain cope better with change and with help the person to adapt. It's given nightly. You want to separate it from any fat, high fat. Fat is super essential, very pro-fat here, but the extended release formulation gets broken down too quickly in the context of a high fat meal that's still in the digestive system. So the immediate release version of this medicine, guanfacine, is not susceptible to that. So that may be a better option for some folks. Improvement might be subtle in the first week or so, but if insomnia was a factor, often people see results within 3 days of starting this, and it can help with experiences in dreams and nightmares, and really help with restful sleep that then helps the next day as well. And it can offset suppression of stimulant, a suppression of appetite that is so common from stimulants. So if it does become apparent that trying a stimulant for attention is worth it, and you think it's an important thing to try, this may be a tool to do that. Oh, we got to go to the next slide. We're still on this old slide. Sorry, I think next, please. Okay, there we go. So yeah. Oh, no, oh, back. Thank you. ADHD with anxiety. I still want to do one more thing. So that's back another one. There we go. Yes, so that's what I was saying, guanfacine, right? Intuniv is the brand name of the extended release form, but immediate release guanfacine is a great place to start, especially if you don't want to run the risk that if there is a side effect, it's going to be a 24-hour side effect, as opposed to starting with the immediate release, giving that a try for a month, and then as long as you know it's cool, then move on to the extended release form. That's once a day. And I wanted to mention also this weight-based technicality with guanfacine that for most people, it is sort of the effective dose is related to weight. I would ignore that and tell your providers, like, I think we just need to start with the lowest dose and see how it goes, and monitor hypertension, monitor blood pressure, monitor how things go, and watch for dizziness. Obviously, we don't want falls, and breathing techniques are something that really help with that. So sometimes there's dizziness in the first day or the first even 4 hours of taking this, and then that completely resolves after the first day or two. So breathing out completely, right? That complete exhale to make space for fresh air. Extended sighs. That is a tool to use to reduce fall risk in initiating medications that lower blood pressure like this, and also clonidine, which is another that I've seen in use with WSS. Also, you can move to the next one, mild blood pressure reducer. So the stimulant treatment, very understandable to want to wait until you've seen growth and as much appetite as you can. Sleep is so essential for improvement of attention processes. So stimulants are always taken in the morning and as prescribed, and you really want to be monitoring the growth and focusing on hydration, because the side effects of this and guanfacine as well can contribute to constipation, reduced motility, which is already a concern, right? And I think the sensitivity to signals that are signals of pain, right? So we all want to be sensitive to the reality that some behaviors are mysterious to providers, but are probably less mysterious to you. You may know, like, oh, this is pain, and you got to find providers who trust you about that. Hydration sometimes is the key to resolving that. Right. So if you're seeing this in the first day or two, maybe it's a sign that you got to get more fluids, more clear fluids. Okay, next. So I wanted to talk about the adverse effects and the concerns about this worry of addiction. Really, if this feels worth treating to you with medicine, the concept of addiction, I don't think is too much of a concern, right? Untreated ADHD overall throughout humans is more associated with craving patterns, right? So maybe with WSS folks, it's less concerning to think that there's going to be some sort of drug-seeking behavior. I don't think that's the concern here. We're talking more about the fact that could there be craving patterns that make things worse in the long run. And I don't think that's too much of a concern with this kind of treatment, especially given that you're going to start with super low doses and really be closely monitoring, right? That's really the appetite that is the bigger adverse effect that you want to be careful of. The shorter stature as a result of appetite suppression is something we know happens from treatment with stimulants in young children, especially long acting, right? So with the stimulant part of attention treatment, I would definitely work on getting providers to provide immediate release unfortunately very hard to get these days, but this is a better bet. And trying to get AM protein, good gut filling things before the medication, which then will make it longer acting if that's what is really needed. Okay, next. Always discuss the sleep, and if you can, find ways to keep a document about your loved one's sleep, about your sleep. Go to providers, ready to tell them everything you can about sleep quality. How long does it take to fall asleep? How is it for you, right? The providers should be asking this, but some will just skip that or forget. But if someone's struggling with winding down, what is the thing that helps? What helps bring the sense of safety and connection to their life, and really build on that with your loved ones and your family systems and teams. Motivational interviewing is sort of asking, like, how can we change this? How can we help? Document an estimate of overnight awakenings. Really try to be as precise as you can about this. And what are you feeling, right? What's happening in the waking up period? I know that shorter sleep cycles may be a reality for you. So if it's 4 hours here and 4 hours there, that's still okay, right? But really aiming for more, especially with the young ones. If sleepy all day, I think it can be really worthwhile pursuing something like Wellbutrin, which is still dopaminergic in the way a stimulant is, but as long as there's no history of seizure disorder, can be a gentler way of bringing some activation to the day. Wellbutrin is not so good if the thing you're worried about is anxiety. Wellbutrin is more for activation, and not a good treatment for anxiety. Okay, next. I struggle to talk about how to discuss this topic because I know we all want to protect our loved ones as much as we can, but the struggle bus is real and trauma is sometimes invisible. It's a felt experience, right? So people who are non-speaking and don't have a way of explaining what is traumatic may be experiencing things like certain types of lighting or certain noises or even tactile senses that might be triggering a sort of pathway of hormones that neurotypical folks wouldn't have without much more extreme states of stress. This book by Mona Delahunt has a lot of really good scientific background on how to stop fixating on the behavior and see what's really underlying it, right? So trying to trust that you can see a pattern with behaviors coming out that might indicate that kind of trauma level of discomfort is overwhelming to a loved one, and really sort of finding ways to engage and calm your own system to sort of really be present, right? To really feel that you're hearing what therapy is looking for, what any educational process is looking for, and looking for consistency with your whole family and the whole caregiving team. I really believe in everyone getting therapy, and getting psych providers who do meds and therapy is a great tool for that. Not always possible to find, but it's a good thing to look for. And I had mentioned clonidine because it can be really helpful for reducing that intense hyperarousal state that trauma can sometimes bring about. So clonidine is another, like guanfacine, technically a blood pressure medicine, but in very low doses seems often helpful for sort of keeping a lid on some of the neurological effects of being overwhelmed, right? Overwhelmed is maybe a better word for this type of struggle bus experience. And the guanfacine ER, if everything is looking good, that's sometimes an option for younger kids and easier to go through with young children, and approved by the FDA for this kind of work. clonidine is easier with older people, 10 and up, and it's expected to be given 3 times a day, TID, if it's oral. But there's a patch that makes it a lot easier for teenagers. I always want to give the oral version first, just to make sure there's not a adverse effect, right? Not too much dizziness. The patch is active for a week, and your provider should be able to help you figure out how to reduce the likelihood of a side effect related to dizziness, if that's a concern. Next. Oh, this is my favorite. I really want to talk about how minimalism in medication, minimalism in interventions is sometimes enough, right? There are some things that can be helpful at super, super low doses. Finally, I've found a commonly available melatonin dose, 0.3 milligrams, that Vicks is making, that's widely available. 1 milligram tablets, I would even say try to break them in quarters. Aim to always keep melatonin really low and skip it when you can. You know, we don't really talk about autism, intellectual disability, and WS. We don't talk about a med for that, right? But what I do see is like the insomnia, the pain struggles, irritability, anxiety, and mood. These are things that we do want to treat. We do want to offer help and find the way to balance how much of a risk we're willing to accept for the possibility that we see a major benefit, that the benefit can be really worth taking that step. I would say just approach the question of treatment with the knowledge that every person is just as much a person and just as much deserving of support as anyone else. I have to validate that there are medical providers out there who do not treat folks in this way, and that is harmful. And if you've experienced that, I am sorry. Really, I want you to insist that providers assess mood, anxiety, and all of these co-occurring things, even with non-speaking folks who can't talk about it. There are still experiences they're having, like sweatiness and shakiness, elevated heart rate. If you're seeing that your loved one has high heart rates, you can always just say, hey, I think we need to check that again when all the white coats are gone, or when we're in a less stressful situation. We aim to have providers speak to your loved one, right? Speak to you directly, always address you, even if you're not speaking back to them. Even if a person with WSS is not speaking directly to the provider, they should still be addressing them and really connecting, trying to connect. If you're not being heard, I do recommend looking for developmental pediatrics practices. The USED system is university groups with a specialty in developmental disabilities. Hopefully psychology departments near you have ideas too. All right, now we're going to, next is a slide that's a little more difficult. Again, I want to talk a little bit about disruptive moods, irritability. This can even become destructive behavior, and the reality that sometimes this requires an extra layer of care and safety. If this is the concern that you're trying to get treatment for, try to have some kind of record of how often it's happening, whether there are head injuries happening, where these incidents occur, what the relationship of these incidents is to nutrition status, to any seizure activity, or to just kind of movement that you're concerned about. If this is happening or things become sort of bizarre, you want to tell your providers that this is the reality and that you're concerned about it. Therapy is still helpful for all of this. Occupational therapy, SLPs with all of their communication tools and the ways that they can work through the body to help loosen up tension and help people be present instead of avoidant or fearful. So empowerment by other tools besides outbursts is what we're hoping for, right? Empowering our loved ones, empowerment to communicate in other ways. So there are some meds that I just want to mention that may have incredible benefit for some folks, even though they're kind of more a secondary try if others have failed to help. Risperidone is available in this very low dose. If you Google that drug, you will find all kinds of scary stuff. Generally speaking, it is because of higher doses, 4 to 8 milligrams. But if labs are available, you can get a knowledge of what the starting status is, and then keep monitoring every year or so how things are going, and you can get benefit from these medicines for sleep, for irritability, risperidone particularly for insomnia and fearfulness overnight, and aripiprazole is on the other end of things, sort of more for daytime struggles if the school day or the learning day is part of the big trouble. Aripiprazole is more of a morning effect. And aripiprazole also has benefit for attention processes too. It's kind of a wider range of benefits besides just reducing irritability in some folks. The risks of these things are very real in terms of alteration of lipid levels in the body, there's potential risk for hemoglobin A1C, which is the measurement of diabetes risk. So if those are family risks that you're already aware of, that's something to be cautious of, and just work on keeping doses super, super low. Micro doses, I would even say. Valproate is something that there is evidence maybe like a thing to avoid. That's Depakote, the brand name. You know, if there are folks still using Depakote, I can't speak to their clinical judgment, but my understanding is that it's probably not a good idea, especially if there's anything going on with cardiac functioning in your loved one. You want to sort of stay away from valproate acid. I want to offer this next tool on the next slide, not just for WSS, but for everyone. We can all benefit from having new ways to think about how we're feeling. And, you know, I think that sometimes we haven't noticed we're escalating or like kind of getting hot-headed. So this is a list of tools, finding techniques to calm ourselves is also going to help calm our family system, right? The dynamic and the tension in any system can be reduced even when just one person finds a way to bring more joy to a moment and discharge the tension. So we've got things like making sure you're being hydrated, getting a shower or a bath, having a walk, right? And having that hopefully prevent the escalation if you can do that when you're just starting to get frustrated. So a lot of it is like noticing our own experience and also noticing how it's affecting others around us and building in tools to sort of keep present, right? Keep trusting that there's going to be a better time, that progress can be right around the corner, even when things are really hard. The next slide is about the fact that there are resources for scary situations when things start to feel out of control and it feels like you're not sure what to do. It varies by state how to connect with this, but finding caseworkers that you trust, asking about respite, asking if family members can be trained to provide respite, and then family members who are trained may even be eligible for payment for doing that. And getting into local social worker networks is sometimes a way to tap into these resources. But I know that all of you are the most amazing resource for each other, more than providers in many cases. And this is an absolutely beautiful thing that I'm so happy and so honored to be able to try to participate in. Okay, next is my last, where I just want to talk about the fact that outcomes are unpredictable, right? So this is why we say that it can be worth taking a risk in order to see if there's going to be a benefit. And know that regardless of how you really feel when you're ending a visit with a provider, you are educating providers about lived experience. And that is essential. That's so important. So don't feel like you have to minimize your struggle. believe in yourself and trust that communicating honestly is the best thing you can do. Thank you so much.